All right, I am showing it is our starting time, so we're going to go ahead and get started with our presentation today. I want to first start by welcoming everybody to our webinar on the Affordable Care Act and the high price of non-compliance. My name is David Lindgren, and I will be your presenter for today. I am a senior manager at Flexible Benefit Service Corporation, overseeing our compliance and public affairs divisions. For those of you attending who aren't familiar with our organization, first off, we go by the name Flex. We are headquartered in Rosemont, Illinois, just outside of Chicago, and we have two primary business divisions. First, we are a wholesale insurance distributor, also referred to as a general agency, working with approximately 4,000 insurance brokers throughout the country. We are also a third-party administrator on a national basis, offering products and administration for accounts such as flexible spending accounts, health reimbursement arrangements, health savings accounts, Cobra, and more. And lastly, just a couple housekeeping items before we get into our presentation today. We are scheduled for 1 hour, and I will do my best to keep us on track with that time slot. For those of you that have dialed in by phone for the audio portion, we have muted your phone lines and are going to keep those phone lines muted throughout the presentation just to eliminate background noise. For those of you that are listening to the audio portion through your computer speakers, please be advised that depending on your internet speed, sometimes the audio can be a bit choppy or delayed, and if you experience either or both, I would encourage you to dial in for the remainder of the audio portion. This presentation has also been pre-approved for one general HRCI recertification credit, as well as one SHRM professional development credit. And in order to receive those credits, we do need you to remain on the duration or remain on the webinar for its entire duration. And in about 2 to 3 business days following the conclusion of today's webinar, we will be emailing out those credits along with a copy of the presentation. So that sums up our introductory comments and housekeeping items. So I think it's safe to now move on to the core of our presentation and the primary purpose of your attendance today. Now, I don't know if I want to use the term humorous, but I'm going to go ahead and use that term. It is somewhat humorous that we are more than 6 years into the passage of the Affordable Care Act, and yet there still seems to be quite a bit of compliance concern amongst the industry, whether you're an employer, a business owner, an HR professional, a consultant, an insurance broker, a medical provider. Everybody seems to be having some trouble fully complying or understanding all the administrative requirements associated with it. And came across a survey not too long ago that was conducted by the International Foundation of Employee Benefit Plans, also known as IFEBP, and they surveyed some employers and asked them which year did they think would be the most expensive year for ACA compliance. And lo and behold, it was this year, with about 1 out of every 3 respondents indicating 2016 would be the most expensive year for ACA compliance. And when I think about that, logically it does seem to make sense, because 2016 is the first year where the employer mandate is being fully phased in, and it's also the first year that Section 6055 and Section 6056 ACA reporting is required, which many employers are subject to. So it does seem to make some sense that we still are having some compliance concerns since not everything was rolled out on the passage date of the Affordable Care Act, March 23rd, 2010. So our agenda here for today is to talk about ACA, hopefully in a little bit of a different way that you may have seen presentations on in the past. First, I want to talk about who are the agencies that are really enforcing the ACA regulations, and what are the consequences for noncompliance, whether they be monetary or otherwise. Then I want to go over the market reforms and notification requirements. I'm assuming many of you are probably familiar with many of those market reforms and notification requirements, but I also want to talk about them, not only just giving you a general understanding of what they are, but what are the consequences for not complying with the reforms as well as the notification requirements. And then I would say probably the last half of our presentation, we're going to go over what I call the 3 big ticket items. The employer shared responsibility, which most people simply refer to as the employer mandate. Then I want to touch on the ACA reporting, And then we'll sort of wrap things up talking about the Cadillac Tax, and then time permitting, we will take some questions and answers. If you do have questions, please go ahead and type those in either to the chat function or the Q&A function that should be on your computer screen. Due to the number of attendees and our limited amount of time, it's unlikely I'll be able to address all of those on today's webinar. But for those that we feel we did not address either during the presentation or during the Q&A session, we'll attempt to reach out to you and answer those in an offline setting. So let's start with our first objective item, going over the regulatory enforcement agencies. And I think at least 2 out of the 3 agencies that are heavily involved in regulating the Affordable Care Act won't be a surprise to you, but the third might. So the first is part of the Department of Treasury. The Internal Revenue Service, or the IRS, is one of the primary regulators and enforcers of the Affordable Care Act rules. And there are some monetary penalties for certain market reform violations that are outlined in Code Section 4980D of the IRS Code. And for these market reform violations in general, failure to comply with one or more of those market reforms will result in a $100 daily penalty per participant, with a minimum penalty of $2,500 per participant. Or for more serious market reforms, a $15,000 minimum fine for violation. And for each market reform, a maximum penalty of $500,000. Now, the IRS primarily enforces the market reform violations through self-reporting using Form 8928. However, for those that are concerned with self-reporting, the IRS generally gives you a pass on the penalties when you do self-report, as long as you were not knowingly and willfully violating a particular market reform. For example, if you were ill-advised either by your insurance broker or an attorney as to how to incorporate a market reform provision or the lack or requirement thereof, and as a result you found yourself in a non-compliant situation, the IRS is generally going to give you a pass as long as once you are aware of the situation you do self-report. So I don't want those monetary penalties to scare you too much. Just be advised they do exist, and if you do discover a market reform violation, it does make sense to self-report in most scenarios. The second agency that administers and oversees the Affordable Care Act, along with a lot of other employee benefit regulations, is the Employee Benefits Security Administration, or the EBSA. They are a division of the Department of Labor. And they have a law which many of you have been familiar with and probably was one of the more comprehensive laws you were dealing with prior to the passage of the Affordable Care Act, and that's the Employee Retirement Income Security Act of 1974, more simply known as ERISA. And under ERISA, participants and beneficiaries do have the right to file a lawsuit against an employer or a plan administrator to obtain monetary damages in connection with noncompliance and or to compel compliance with a particular provision. So keep that in mind, that noncompliance may give your plan participants and beneficiaries the right to file a suit should they feel adversely affected by that noncompliant matter. And the last agency is one I think that usually comes as a surprise when we're talking about regulating employee benefits, and that's the Occupational Safety and Health Administration, also known as OSHA, also a division of the Department of Labor. And when I think about OSHA, I typically think about OSHA getting involved in work-related injuries, or possibly an employer who, or an organization who is disposing of hazardous waste improperly. That's what I think about when I think of OSHA. I don't think about them typically getting involved with employee benefit regulations, but believe it or not, OSHA is involved with several whistleblower rules. And under Section 1558 of the Affordable Care Act, there are whistleblower rules that provide some certain rules and protections so that employees and plan participants are not discriminated against in certain situations. One of the primary discriminatory issues that the regulators are concerned about in this scenario, OSHA, is an employee who is discriminated against for receiving a subsidy in the exchange or in the marketplace. As we discuss more later in the presentation on the employer mandate, the ultimate trigger of a penalty under the employer mandate is when a full-time employee is not offered coverage or is not offered affordable coverage with minimum value, and they end up going to the exchange and receiving a subsidy. That's the ultimate trigger of a penalty. So the OSHA whistleblower rules are designed to prevent discrimination against an employee, such as terminating their employment or reducing their hours for the sole reason of receiving a subsidy in the exchange. OSHA also has protections for employees and plan participants who are providing any sort of information or participating or are testifying in any sort of judicial proceeding in relation to a violation of Title I of the Affordable Care Act. Title I of the Affordable Care Act is designed, or at least attempts to provide affordable access to coverage to all Americans in the country, and includes certain provisions such as the requirement to waive any sort of pre-existing condition waiting periods for any ongoing or prior medical condition. Also provides protections for any sort of employee or plan participant who refuses to participate in an activity or a policy that the employee believes is a violation of Title I of the Affordable Care Act. And for those employees or participants who do file a whistleblower claim and are successful in their claim, some remedies for violations may include reinstatement to the extent their employment was terminated or a return to the previous position in which they held. Compensation could be in the form of back pay, front pay, as well as payments and costs for any sort of expenses incurred, such as legal fees. So we've got those three primary regulatory agencies. We also have the Department of Health and Human Services. They don't typically get involved with the actual enforcement of the Affordable Care Act, but they are heavily involved in drafting some of the rules and clarifying some of the rules. So really when we're talking about our regulators, it is the IRS, the EBSA, as well as OSHA. So that being said, I want to now talk on our second objective, what I refer to as reforming your health plan and adapting to new market reforms. I think this section, most of what I'm going to cover, I believe many of you are probably already familiar with, and I would suspect most of your plans have adapted to these market reforms, but just want to give a quick overview of what those market reforms are and what the consequences are for noncompliance with those reforms. So the first 6 market reforms apply to both grandfathered and non-grandfathered health plans. A grandfathered health plan is a plan that was in force prior to the passage of the Affordable Care Act on March 23, 2010. And a non-grandfathered plan would be a plan that was issued or in force after March 23, 2010. So I already sort of alluded to the first market reform, but under all health plans, whether they be fully insured or self-insured, individual coverage or group coverage, there is no longer the ability to have a pre-existing condition waiting period. So any sort of medical condition that a plan participant has must be covered on the first day that they enter into the plan. The second market reform that comes up is that health status cannot be a factor in determining eligibility for coverage. So no longer can medical history be a indicator as to whether or not an employee is eligible for coverage. However, there are wellness programs that employers can incorporate, and based on the success of participating and completing the requirements of that wellness program or not, employees can be charged different rates, but their actual eligibility for coverage cannot be a factor into whether or not they can enroll in the plan. Just those wellness programs can impact rates. The third market reform that applies to both grandfathered and non-grandfathered plans is the requirement to cover dependent children up to age 26. Please be advised that some states do have requirements that go above and beyond that for fully insured plans, but the ACA requirement did really set a more uniform national standard that coverage, regardless of student status, must be made available up to age 26. For those of you that are familiar with essential health benefits, also referred to as EHBs, there's 10 of them. Just to give you an example, hospitalizations, prescription drugs, pediatric care, maternity coverage, mental health would be 5 of the 10 essential health benefits. Not going to name them all just for time constraints. But all essential health benefits that are covered under a plan must now be covered without any annual or lifetime dollar limits. In some situations, for things like physical therapy and speech therapy, a plan may be permitted to use a visit limit, but they cannot have any annual or lifetime dollar limits imposed on essential health benefits. The fifth market reform here that applies to both grandfathered and non-grandfathered plans is that waiting periods cannot exceed 90 calendar days. It's not 90 business days. It's not the first day of the month after 90 days of employment. It is 90 calendar days. In some instances, for some positions, there is an exception to that rule. The Affordable Care Act does allow for a 30-day orientation period and then 90 days of a waiting period, but that's only for certain positions which require an employee to perform certain actions in order to maintain their employment. I like to use a stockbroker as an example. An employer that hires a stockbroker may require that stockbroker to obtain their Series 7 within the first 30 days of employment. Otherwise, their employment would be terminated. And in that scenario, that stockbroker organization could impose a 30-day orientation period followed by a 90 calendar day waiting period. And the last market reform here on our slide is that coverage cannot be rescinded. Rescinded is a fancy term for retroactive cancellation, except in cases of fraud or material misrepresentation. And for those 6 market reforms, failure to comply with one or more can result in penalties by the IRS under Code Section 4980D, or penalties through the Employee Benefit Security Administration under the EBSA code if an employee should choose to file suit against the employer. Now, our next set of market reforms only applies to non-grandfathered health plans. So for those plans that were in force prior to the passage of the Affordable Care Act on March 23, 2010, and those plans have not experienced any sort of material modification, these rules do not apply. There are fewer and fewer grandfathered plans that exist each year because it becomes hard not to make changes to those plans to alleviate some of the premium increase. So most plans today are subject to these market reforms, but to the extent your plan is grandfathered, you don't have to worry about these market reforms, at least at this time. But the first one here that applies to non-grandfathered plans only is that in-network preventive care must now be covered at 100% with no cost sharing to the member. And that is, of course, only for in-network services, does not apply to out-of-network. There's also certain women's preventive services, such as prescribed birth control, that must be covered at 100% with no cost sharing to the woman. Please be advised here, there are some religious exemptions that may apply where the plan would not be required to provide prescribed birth control at no cost to the individual. There are also 3 patient protections that are now required of all health plans, fully insured as well as self-insured in the non-grandfathered market. And that is the freedom to select a primary care provider or pediatrician within the plan network. So the plan cannot assign one, must give that participant or beneficiary the ability to select their own. The plan cannot require any pre-authorization or referrals for OBGYN or emergency care. And out-of-network emergency care must be covered according to in-network terms. Failure to comply with these market reforms also results in potential penalties, monetary penalties by the IRS, as well as gives employees the right to file suit under the ERISA law. Continuing on with some other non-grandfathered market reform requirements, plans must have an internal and an external claims appeal process in place. Many plans prior to the passage of the Affordable Care Act only had an internal appeals process. Now plans are required once the internal appeals process has been exhausted. There has to be the ability to have a next step involved where an unbiased third-party entity reviews the claim that was denied and makes a determination as to whether or not that claim should be processed and approved or continue to be denied. Plans must now cover, non-grandfathered plans, of course, must cover approved clinical trials. Health plans cannot discriminate against a medical provider who is acting within the scope of their medical license. For example, a family care physician who also administers dermatology care, as long as that's within the scope of their license, the plan cannot require the participant to see a dermatology specialist. Health plans are also subject to a maximum out-of-pocket limitation. For 2016, that is, or 2016 plan years, I should say, that is $6,850 for an individual, $13,700 per family. And if you do have family coverage, a plan that covers 2 or more participants, no participant can experience more than a $6,850 out-of-pocket maximum on a family plan. And something we've been waiting for a few years for rules to get issued that still have not been released are, in the event you have a fully insured plan, fully insured plans are supposed to be subject to non-discrimination rules under the Affordable Care Act. That was supposed to take effect back in 2011. However, due to delays by the IRS, these rules have not yet been issued, but they are expected to be issued at some point later this year, at least according to some informal comments by IRS officials. And the intent is that, like self-insured plans and other types of plans, FSAs, HRAs as an example, there are certain rules in place so that the plan does not discriminate in favor of highly compensated employees or highly compensated individuals. And those rules are now going to trickle down to fully insured plans as soon as the IRS gets around to issuing guidance on that. Again, potentially expected to be later this year. And failure to comply with these market reforms can result in monetary penalties by the IRS, as well as gives employees the right to file suit under ERISA. Now I want to talk about some notification requirements. There are several new notices or other requirements that the Affordable Care Act imposes on plan administrators. In some instances, if you have a fully insured plan, the notices will be provided by the carrier. In other instances, the notices have to be provided by the employer. If you operate a self-insured plan, you should make sure you understand who has the responsibility of delivering those notices on a timely basis. But I think when we talk about the notices, you'll seem to think it makes sense as to why these notices are required. And the first notice that I'll discuss is simply if your plan is grandfathered. Again, it was in place prior to the passage of the Affordable Care Act and has not experienced any material modifications since that time, you are obligated to make sure your plan participants receive a notice which indicates that plan is grandfathered, and that notice describes some of the things that may not be covered as a result of its grandfather status. Unfortunately, if you are failing to provide that notice, the penalty is not necessarily a direct monetary penalty, but it is a loss of grandfathered status, meaning you're going to end up having to get rid of that health plan and migrate to a non-grandfathered health plan that must conform with all of the ACA market reforms. The next notice, I mentioned the term rescission before, and that's a retroactive cancellation due to fraud or material misrepresentation. In the event that occurs, as the plan administrator, you are required to provide participants with written notice indicating that the coverage was rescinded and why it was rescinded. And to the extent you rescind coverage but fail to provide notice, that ultimately results in the rescission being invalidated, meaning that individual should be allowed to stay on that health plan. Our next notice here that we're going to discuss involves those 3 patient protections that we discussed. The freedom to select a network provider of your own, the requirement to the lack of a requirement to force people to have referrals for OBGYN or emergency care, and the requirement to cover emergency care according to in-network terms. Those 3 patient protections must be described through a written notice, and oftentimes if you have a fully insured plan, the carrier will just include that notice right with the certificate of insurance booklet. As a self-funded plan, you need to check on how that form is being delivered. But failure to provide that notice, just like failure to have these benefits or market reforms incorporated, can result in penalties by the IRS and gives the employee or plan participant the right to file suit under ERISA. The next, we talked about that claims review process. So market reforms oftentimes come with notification requirements, as we've seen a few of them already. Plan participants must be provided with a written notice about the internal and the external claims review process that we discussed previously. And again, penalties here can come under IRS as a monetary penalty and the right to file suit under the ERISA statute. The summary of benefits and coverage, hopefully you are familiar with that, and that has a associated document referred to as a universal or a uniform glossary of terms and definitions. That summary of benefits and coverage, along with that glossary of terms and definitions, must be provided to plan participants at certain times. This is the plan administrator's responsibility. Oftentimes, the insurance company will prepare the summary of benefits and coverage for you, but ultimately it's up to the plan administrator to deliver that summary of benefits and coverage at the appropriate times. For example, the SBC should be provided at open enrollment with all the other open enrollment materials. It should be provided 60 days prior to any mid-year material modification, and it should be provided upon request as well. So just keep that in mind. There are 5 or 6 different times that this notice needs to be distributed, and failure to provide it within the appropriate time as indicated under the Affordable Care Act law can result in a penalty of $1,000 for each violation. So here we have an instance where we have a specific statutory penalty that doesn't fall just under this general $100 per day penalty under Code Section 4980D, or doesn't fall under the necessarily fall under the ERISA statute. Here we have a specific penalty that's outlined under the ACA that applies to the SBC. For those of you that are familiar with the marketplace, there is a requirement. It went back October 1st, 2013 was the first day the marketplace was open for business, although there were some technical difficulties the first several weeks of its launch. But back in October of 2013, you were required to give a marketplace notice. It essentially notified employees with information about your health insurance plan. If you did offer one, was it affordable? Does it provide minimum value? Provides information about alternatives that employees have where they can go to the marketplace and potentially apply for an individual subsidized plan. That is no longer required to be given to your existing employees on an annual basis, but it is required to be given to all new hires within 14 calendar days of their start date. And this is all new hires, whether they're benefit eligible or not. And the only exception to the rule is if you're an employer who is not subject to the Fair Labor Standard Act, you're not subject to this requirement. Generally, if you have revenues of $500,000 or more, you are subject to the Fair Labor Standard Act. But the interesting thing here is, although they say it is a requirement for you to give it to all of your new hires, the Department of Labor has specifically indicated that there is no penalty for failure to comply with this one. So a little bit of a break, at least on one of the notification requirements. And then this is sort of an indirect impact. This wasn't necessarily specific in the original Affordable Care Act law, but sort of as a side effect, I'll call it, your Cobra general and election notices, assuming you are an employer who is subject to the Cobra law, must now be updated to reflect marketplace details. Essentially, it gives employees or Cobra beneficiaries information about alternatives that are available to them through the marketplace, also referred to as the exchange, and lets them know that there may be more affordable options through that avenue. And failure to comply and update your Cobra notices, just the general and the election notice, need to be updated. Of course, again, I've said it several times, but can result in penalties by the IRS as well as the right to file suit under the ERISA law. And the last notice isn't necessarily a notice, but I'll call it a disclosure, is for those of you that have W-2s, I guess we'll call you medium to large size businesses. If you have or are issuing 250 or more W-2s, then there is a requirement, assuming you do offer health coverage to your employees, there's now a requirement to provide the value of coverage on that W-2. And it's for informational purposes only. I know several employees think it's a taxable item on their W-2. It's just for informational purposes only, but it is a requirement. And failure to disclose that information, penalties can be rather high. Of course, the larger you get the greater the penalty. But penalties can start at on the bottom end at $50 per Form W-2, and they can go up from there up to a maximum penalty of $3 million per filing year. And those penalties vary depending on the number of failures and when and if they are corrected. So something, if you are issuing 250 or more W-2s, you really want to make sure you're doing that part correctly. Now, I said for the last half of the presentation, which I think we're directly or exactly at the halfway point, I want to talk about what I call the big ticket items. These are the questions, or I'll take a step back. Most of what we've just talked about, in my findings, in my experience, I think most employers, HR professionals, brokers, whoever you are, if you're involved in some way, shape, or form with plan administration or benefit decision making, you seem to have a pretty good handle on that stuff. That's not where we get a lot of questions on. It still continues to be questions around the employer mandate and the associated reporting, as well as the Cadillac Tax. So I wanted to dedicate some extra time to these specific items because they do require a little bit more of an explanation. They're not as simple as explaining a waiting period or explaining a certain notice that has to be provided. These are a little bit more in-depth. So some of this you may be aware of, some of it you may not. My goal is that you at least have a refresher of this and hopefully a couple takeaways here. But when somebody asks me, can you explain to me the employer mandate, it's not a simple answer. There's really what I call 5 buckets or 5 components to the employer mandates. And you'll see a chart on your screen here. It is that applicable large employers must offer coverage to full-time employees that has minimum value and is considered affordable or risk penalties. So if you're an experienced person in the industry, you might understand that rather easily, but for those of you that are, still trying to figure this out, we've really got to define each one of those boxes, and that's exactly what I'm going to do for you here. So I want to start here by talking about who is an applicable large employer. Oftentimes we just call them ALEs or ALEs. But an applicable large employer, at its highest definition, is an employer with 50 or more employees. So for several of you on the call right now, it's pretty easy to make a determination whether or not you are an ALE. But for some of you, you might be, sort of hovering around that threshold. And just to break down that 50 or more employees, it is based on the average number of employees you have on business days during the prior year. So if you're to be an ALE in 2016 is based on how many employees you had in 2015. But if you're a newly formed business, there is a special rule that says you must reasonably expect and actually employ an average of 50 or more employees during the first year to be considered an ALE. So there is some subjectivity and some assumptions there that does come into play, at least for certain newly formed businesses. If you are a part of a controlled or affiliated group, as defined under IRS Code Section 414, you are considered an ALE based on your controlled group size. So if you are a part of a control group and let's say there's 2 organizations within that control group, one has 30 employees, one has 40 employees, you do have to combine those to determine whether or not you're an ALE, and in that scenario, you would be. And then employer size is based on the number of full-time employees you have, plus the total number of full-time equivalents. So that's going to move us into our next box here. You've got to offer coverage to a full-time employee. Who are the full-time employees? And the Affordable Care Act under the employer mandate regulations has a specific definition as to who is a full-time employee. You might use a different definition for other benefits such as your 401k plan or any other type of benefit, but when we're talking about the employer mandate, we're really talking about the medical plan. And under the employer mandate, it says a full-time employee is someone who provides, if you're measuring weekly, 30 hours of service per week, or if you're measuring monthly, 130 hours of service per month. And they use this term hours of service, which I think needs a little bit of explanation, but I think it's simple to understand once you have that explanation, is an hour of service is an hour actually worked by an employee plus any hours that they are additionally paid for. So for example, if somebody has paid vacation, paid sick time, paid leave, jury duty, bereavement leave, whatever it is, if they're getting paid for it, you need to include that as an hour of service in determining their full-time employee status or lack thereof. Now, when we're talking about your part-time employees, we're really talking about how many part-time employees equal one full-time equivalent employee. And there is a formula, and we're really only determining full-time equivalents when we're trying to figure out whether or not an employer is or isn't subject to the employer mandate. Maybe they have 40 full-time employees and 30 part-time. Well, we've got to figure out how many full-time equivalents did those 30 part-time make up. And the formula that the IRS has provided is that you would take the total monthly hours of service by all part-time employees, and then you would divide that by 120, and that would give you your total number of full-time equivalents. Now, for some employees, it gets a little tricky. Many of you might have variable houred employees. They're going to work, they might work 1 week less than 30 hours, the next week more than 30 hours. It's just they fluctuate. So you have a determination of, you have two options. One, you can just offer them coverage once they do hit a 30-hour a week or 130-hour a month point. And then if they drop down, then you reduce their benefits. That becomes quite an administrative challenge, though, because you have people that are coming on and off the plan based on their fluctuating hours. So the alternative and the more commonly adopted way of handling variable houred employees, at least in lieu of the Affordable Care Act, is to measure a prior work time to determine whether or not over a period of time that person averaged full-time status, and if they did, you would then offer them coverage in a subsequent plan year. So there is what's referred to as a measurement period, and the ACA says if you truly have a variable houred employee, you're uncertain if they're full-time or not, you can measure them for a 3 to 12-month time period. You select which time period is appropriate for your organization. After that time period is ended, you have up to a 90-day administrative period, and that administrative period is really where you've gathered the data, now you're analyzing it to determine who is or who isn't a full-time employee. And then for those variable hours that measured full-time, you then would offer them coverage through what's called a stability period, and that stability period must be at least 6 months and not shorter than the duration used for the measurement period. So if you use a 9-month measurement period, you'd have to have at least a 9-month stability period. When I talk about measurement, administrative, and stability periods, just using text, it seems to be a little difficult for people to understand. So I also like to throw in a chart. And this is just one example. This is just one of many examples of how an employer might use these three associated periods. And I've got just a hypothetical company here, and we're going to assume they use a 10-month measurement period. They're measuring their variable houred employees to figure out who is or who isn't full-time over that 10-month period. And then for the months of November and December at the end of the year, they're going to use that time period, typically the month of November, to analyze the data, figure out which variable houred employees are full-time or measured full-time. And then during the month of December, when they roll out the open enrollment materials, they're going to also roll those out to any of those variable houred employees who, during the measurement period, average 30 hours per week or 130 per month. And then those variables who elect have up to 12 months to stay on the plan. So that is just one example of how the measurement, administrative, and stability periods could be used. And I think illustrating it graphically makes a little more sense. So next is minimum value. Health plans must have, that are offered in order to avoid any potential penalties, must also include minimum value, a new term that was introduced through the Affordable Care Act and under the employer mandate regulations. And minimum value translates to a 60% actuarial value. Well, when you tell somebody that, it's really, well, what does that mean when we're talking about insurance? And what it means is that the health plan is expected to cover 60% of the total cost of benefits for a standard population. As an example, if $1 million in claims were submitted to a health plan, that health plan would be expected to pay out at least $600,000 in claims, leaving the remaining $400,000 to the participants in the form of out-of-pocket deductibles, co-pays, co-insurance, et cetera. A lot of people misunderstand that to think at the individual participant level, the plan's going to pay out at 60%. That's unfortunately falsely, it's a false statement. It is based on a standard population. So for example, if you have a self-insured plan, it's going to be based on everybody that's covered under that self-insured plan. So it's not specific to one person, but a standard population. If you're uncertain whether or not your health plan has minimum value, the summary of benefits and coverage has to indicate whether or not the plan has minimum value now. So if you have a fully insured plan, that would be the starting point. If you have a self-insured plan, that would probably be the starting point as well. But if you're involved in making, if you have a self-insured plan and you're involved in making the minimum value determination, the Centers for Medicare and Medicaid Services, CMS, has a calculator out there where you essentially enter in information about your plan. I believe they use an Excel template, you enter information about the deductible, which essential health benefits are covered, and then from there, it tells you an actuarial percentage, and if that's 60% or greater, then your plan is considered to be, or considered to have minimum value. Alternatively, if you have a self-insured plan, you could seek professional actuarial advice, but that would ultimately be up to you. All right, so our next bucket here, coverage must also be considered affordable in order to avoid the risk of any potential penalties. Affordability has a lot really to it. I wish it were more simple, but it's not. And for the 2016 plan year, you have to really follow the bullets and follow them slowly. But we're talking about the employee's share of premium for self-only coverage for the lowest cost plan that's offered with minimum value is not more than 9.66% of household income. So we're just looking at the employee share of premium, after employer contributions. We're only looking about what it would cost if they covered themselves, not their spouse or their children or anybody else. If you offer multiple plans, we're looking at the lowest cost minimum value plan, not necessarily the plan they enroll in, and then what they pay for that plan or would pay for that plan if they enrolled in it cannot exceed 9.66% of household income. That 9.5% number that many of you may be familiar with has been inflation adjusted to 9.66%. Now, what oftentimes comes up is household income. Who knows that, or who even wants to know that at the employer level? So assuming you don't know household income or don't care to know household income, you do have three alternatives in determining whether or not coverage is affordable. And the first safe harbor is referred to as the W-2 safe harbor. The unfortunate thing with the W-2 safe harbor is you really can't apply it until the year is over because you don't know specifically what somebody's wages are until the end of the year. They could have bonuses, they could have raises, they may have some unpaid leave. You don't know what their true W-2 wage is until the end of the year. Of course, for your higher income earners, it might be a little easier to speculate, but for people that may be otherwise eligible for subsidies in the exchange, it might be a little more challenging. So you want to base that off of box 1 on the W-2, and if what the employee would have to pay is 9.66% or less, then you would be considered affordable using that W-2 method. A little bit of an easier method, I think, is the monthly rate of pay, but this does, vary, on an employee-by-employee basis. But you take a look at what their pay is at the start of the plan year, and if you have an hourly employee, you're going to calculate their monthly rate of pay as whatever their hourly rate is at the start of the year, multiplied by 130 hours. Remember, that's what the definition is of a full-time employee using the hours of service that we discussed previously. So don't worry about what they actually worked. We're just using 130 times their hourly rate. And as long as that, when you take that number, let's say you have a $10 an hour employee times 130, that's $1,300. If we take 9.66% of that, as long as that number, I don't know that off the top of my head, but as long as that premium charged to the employee is that number or less, it would be considered affordable. For your salaried employees, you're just going to take 1/12 of their salary at the start of the plan year and base the affordability as 9.66% or less than that. Just be advised, if you're using the rate of pay method and you have employees who receive any payments by virtue of tips, maybe you have a restaurant, or you have employees who are paid exclusively by commissions, this method cannot be used. Then you can also use the federal poverty level method, and under this method, you base affordability in relation to the mainland federal poverty level for a household of one. The 2016 federal poverty level just came out at the end of January. That's $11,880. And that number I do know, 9.66% of that gives you a premium of $95.63. And if you're charging employees $95.63 or less per month for that lowest price minimum value plan, coverage would be considered affordable. So you can use any of these three methods, whichever you think is most appropriate for your organization. So let's talk about the penalties now. So we've talked about who is an ALE, who is a full-time employee, what's minimum value, and what's affordable. So what are the penalties? So I'm going to talk about 2015 penalty first, because right now many of you are completing reporting as it relates to the 2015 plan year, plus the employer mandates being phased in from 2015 to 2016, so there's some slight variations. But there's really two potential penalties. They actually refer to them as assessable payments. I like to think of that as a fancy term for penalties, but call it what you will. And there's really two potential penalties. First is, did you offer health insurance coverage to enough of your full-time employees? And then the second penalty is, did you offer coverage which was affordable and or had minimum value? And failure to meet the offer percentage or failure to provide coverage which is affordable and or provides minimum value can trigger a penalty. So the offer requirements for the 2015 plan year were to offer coverage to 70% of the full-time employees. Failure to do that exposes you to penalties under IRS Code Section 4980HA. And then the second potential penalty is, let's say you met the offer requirements, but maybe you didn't offer to all employees or all full-time employees, or coverage didn't have minimum value or wasn't unaffordable. And for the 2015 year, the affordability percentage is 9.56%, not 9.66%. Failure to do that can result in penalties under Code Section 4980HB of the IRS Code. So let's look at the penalties. They have been inflation adjusted. You may have recalled the number 2,000. That has been inflation adjusted even for the 2015 year. Originally, the employer mandate was scheduled to take effect in 2014. It then was pushed back to 2015 and then was phased in for 2015 into 2016. But as a result, we still do have inflation adjustments even for the first year. But this penalty comes into play when you don't meet the offer percentage. And I want to take a step back, actually, because I think I jumped a slide. Apologize for that. Taking one step back, the 2016 penalty, your only changes are the offer percentage goes up to 95%, and the affordability penalty goes up to 9.66%. Apologize for jumping that slide there. But going back to this slide, the 2015 penalty is $2,080. The 2016 penalty is $2,160. But this comes into play when the offer percentage is not met, so did not offer to 70% in 2015 or did not offer to 95% in 2016. But it only comes into play if one or more full-time employees receives a subsidy in the exchange. And if that happens, the penalty is multiplied by the total number of full-time employees, but you get a break on 30 of those employees. You actually get a break on 80 of those employees in the 2015 year as part of the phase-in approach. And it should be noted that the penalty is prorated on a monthly basis. So maybe, let's say you only offered coverage for half the year, then you would be subject to a prorated penalty of half of those dollar amounts. So just giving you an example, let's say we had a hypothetical company, XYZ. They had 110 full-time employees. They did not meet the offer requirements for the entire year. And we're going to assume that at least one full-time employee, received a subsidy through the exchange for the entire year. So we break it down. You take the 110 full-time employees. We're going to get a break on 80 of those employees in 2015, on 30 of those employees in 2016. We're going to multiply those numbers by the applicable penalty amounts. And as you can see, some sizable penalties for an employer that has 110 full-time employees. Obviously, the larger you grow, or the larger you are, the more those penalties can be. So our second penalty under the employer mandate, this applies when you don't offer, or when you meet the offer requirements, but coverage is either not affordable or does not have minimum value, or a combination of both. And this penalty comes into play. It's $31.20 per employee in 2015, $32.40 per employee in 2016. This penalty comes into play when full-time employees opt out of the employer plan, or maybe they weren't even offered it, and they go and receive a subsidy in the exchange. And this penalty only applies to those receiving a subsidy, so it doesn't apply to the whole group with a break of 30 or 80 employees like the previous penalty. This penalty is also prorated on a monthly basis. And I think it's best to show an example here. We're going to have that same company, XYZ, 110 full-time employees. We're going to assume they meet the offer requirements, but for 10 employees, coverage is unaffordable. And of those 10 employees, just 4 of them end up going to the exchange and receiving a subsidy. We're going to take those 4 employees and multiply it by the applicable penalty amount. And as you can see, the penalty here in this scenario is far less than the penalty that applied for failing to meet the offer requirements. Okay, got a couple other big ticket items before we wrap things up here. And the next big ticket item I want to talk about is the new ACA reporting requirements. Those are, many of you are in the middle of getting this finished as we speak. But there are new 2 code sections as part of the IRS statutory code, Section 6055 and Section 6056. Under Section 6055, reporting is required, and the primary purpose that it's required is to help enforce the individual mandate. The individual mandate is that requirement that most people in our country have to now have a qualified health insurance plan, also referred to as minimum essential coverage, or risk paying a penalty on their tax return. That penalty for 2016 is the greater of $695, or 2.5% of your household income. And under 6055 reporting, employers must, or I should say, reporting is required for every person who's covered under the health plan. The employee, the spouse, the children, domestic partners, retirees, independent contractors, board members, Cobra beneficiaries, whoever is covered. Reporting is required, and the months of which they were covered during the prior calendar year. Now, luckily, if you have a fully insured plan, the insurance company is going to do this reporting on your behalf. If you have a self-insured plan, you're subject to completing this reporting on your own. And then under the 6056 reporting, the primary purpose for this is to help enforce the employer mandate, and each ALE is responsible for completion of the reporting. So I want to just show you a quick chart. For employers that have fewer than 50 employees, so you're not an applicable large employer, you only have to worry about reporting if you have a self-insured plan. And there's going to be forms you have to complete, forms 1094B, and then one form 1095B for each person or each primary insured that's covered under the plan. So your reporting, small group, self-insured, your reporting is being used for the individual mandate purposes. But if you are an applicable large employer, you're going to have responsibility for some reporting. Whether you do it on your own or you outsource it, you're subject to it. And if you're 50 or more employees with no coverage or a fully insured plan, you're going to have to complete forms 1094C and 1095C for each full-time employee. You're just going to have to complete 2 of the 3 parts on form 1095C. But if you're an applicable large employer with a self-insured plan, you're going to have to complete all 3 parts of form 1095C, and that's because you're subject to 6055 reporting on the individual mandate, as well as 6056 reporting for the employer mandate. So just understand which forms you are responsible for. And the due dates were extended for this first reporting year, so we're kind of in the middle of this right now. For the 2015 calendar year, you were supposed to have provided the applicable copy of Form 1095B or 1095C to your employee population, or what they refer to as responsible individuals, the primary applicant or the primary insured. You were supposed to have given that to them by March 31st, 2016, And then copies need to be filed to the IRS by May 31st if filing manually, by June 30th if filing electronically. If you're filing 250 or more forms, you're required to submit electronically. And then this is being phased in next year, reporting for the 2016 calendar year, which will be done at the start of 2017. It's going to be subject to the same deadlines as W-2 reporting. Going to have to get copies of the forms to the responsible individuals by January 31st, and then copies to the IRS by February 28th if filing manually, March 31st if filing electronically. And if you don't want to do the reporting, there are some costly penalties. Penalties can actually be as high as $500 per person. It's a $250 penalty for not filing with the IRS, and a $250 penalty for not providing a copy to the responsible individual. Penalties are capped at $3 million per filing year, so that's a rather substantial penalty. And I do want to point out that there are other penalties that can apply if the reporting is incomplete or inaccurate, but the IRS has released guidance that indicates at least during this first reporting year, penalties are not going to apply for inaccurate or incomplete reporting. So they're really saying, give it your best shot. We know this is new and it's an administrative challenge. Give it your best shot to do it accurate, and if it's inaccurate, they're not going to ding you with an extra penalty there. But failing to do it at all, if you are subject to it, can result in a penalty. Last thing, just quickly, a few comments on the Cadillac tax, just because we actually don't have a ton of guidance on it yet. But formally, it's referred to as the excise tax on high-cost employer-sponsored health plans. The industry just calls it the Cadillac tax. It was supposed to take effect in 2018. It's now being delayed. Its implementation date will now start in 2020. And it essentially imposes a 40% excise tax on values of coverage that exceed certain thresholds. There is a belief, at least by some regulators, that people that have a really rich benefit package might tend to overutilize medical services or receive treatment that's unnecessary. So this is an attempt to curb that overutilization of medical care. And they've come up with some values that are going to be inflation adjusted, and I'll describe those values momentarily. But the values that are indicated in the formal regulations state it's $10,200 for single coverage and $27,500 for family coverage. They seem high, but when you start to add in all the benefits they're going to include, it may not necessarily seem that high anymore. But they have indicated there will be some increased limits for health plans that cover high-risk professions. You know, for example, a health plan that covered police officers or firefighters might have a higher limit. And limits are likely going to be increased for employers that have certain characteristics that differ from the national average. For example, if you cover an older population or you are in a more urban area, plans in New York City tend to cost a lot more than plans in rural, Alabama. So there may be some demographic characteristic adjustments, but waiting on some more official guidance on how that will actually be phased in. Now, we really don't have any formal proposed guidance yet on the Cadillac tax, but the IRS has issued 2 notices which they sought public comment on, essentially indicating how they thought they might roll this out and asking for some feedback on that. And they indicated that at least some of the plans that they're thinking about including in the value of coverage would be the medical plan, of course, and that would be the Cobra applicable premium, so both employer and employee contributions included. Any contributions, whether made by the employer or the employee to a health FSA or an HSA. Now, they did indicate employee HSA contributions made outside of the employer would not be included, but if the employee is making pre-tax salary reductions to their HSA, that would be included. Hospital indemnity, fixed indemnity, and specified disease plans like critical illness or cancer plans would be included, but only if they're being paid for on a pre-tax basis through salary reduction. Health reimbursement arrangements, as well as on-site medical clinics. Now, the interesting thing is, how are we going to determine the value of some of these things? Like, what is the participant value of an on-site medical clinic? So that's one of the administrative challenges that exist with the Cadillac tax. Other administrative challenges are that the excise tax is determined separately for each employee, It's based on coverage the employee actually elects, and it has to be determined on a month-by-month basis. So those values I showed you will be prorated on a monthly basis. So this is a whole lot more administrative work when it comes to evaluating this information than it is with the employer mandate, which really utilizes a benchmark plan, the lowest price minimum value plan, whereas the Cadillac tax, we're looking at what did the employee actually elect. And then the plan sponsor is going to be the one that has to determine, what the value is and when an excise tax applies, but then it becomes who pays the tax. And based on some of this preliminary information issued by the IRS, they're indicating that the insurance company is going to have to pay it on the fully insured plan. The plan sponsor would have to pay it for any sort of self-funded plan, but in some instances, they consider the third-party benefits administrator as the plan sponsor. So a lot of administrative challenges still exist, but 2020 is not too far out, and we'll have to see what the guidance tells us at a future date. So a couple final comments here. This was meant to be an informative presentation. I hope I didn't scare too many of you. A lot of challenges still exist, but it should be noted that the Department of Labor has a goal of auditing every American business for compliance by 2018. Now, I don't know how realistic that goal really is, but they're going to be more aggressive and more audits are going to be coming. And if you haven't experienced an audit in the past, you might want to do some research on what sort of things they look for when they do an audit. There's a lot of compliance challenges, and along with compliance challenges comes administrative challenges that I really think are going to continue for the next 3 to 5 years. We're still all figuring out the employer mandate, the reporting, and now having to plan for the Cadillac tax. So we know more guidance is going to come. Things are going to change, get modified. Some things could get repealed. And then, of course, we have this big election coming up in November, and depending on who is elected, really is going to tell us a little bit more as to whether or not we think a lot of things with the Affordable Care Act are going to change or not. So more to come, a lot to plan for. With that being said, I hope I didn't speak too fast, had a lot of material to cover. My clock shows I'm right at 12 noon Central Time, so I am going to open it up just for a couple of questions. And as I mentioned before, if I don't get to your question, we will try to connect with you offline. But if you do have a question, you're more than welcome to type it into the Q&A function. There is a couple questions. Can we get copies of the slides? Absolutely. We will send out copies of the presentation slides along with anybody who's looking for those continuing education credits through the HRCI or through SHRM. We'll send that out in the next 2 to 3 business days. Great questions there. There's a question, if only one employee gets a subsidy, will we be penalized for every employee? And it depends on which, we're going back to the employer mandate. There's 2 requirements. If you fail to meet the offer requirements, which for the 2016 plan year is offering to 95% of full-time employees. If you fail to meet that offer requirement and just one full-time employee goes out and gets a subsidy, then yes, you are penalized on the total number of full-time employees, but this year you do get a break on 30 of them. So if you had 100 full-time employees, you'd be penalized on 70 full-time employees because of that break for 30. Now, if you met the offer requirements, but coverage was not affordable or did not provide minimum value, or maybe you offered exactly to 95%, but there was 5% of full-time employees you didn't, and those full-time employees go out and get a subsidy in the exchange, then you're just penalized on those employees who receive a subsidy in the exchange. Great question there. There's a question, will there be audio file for the presentation? I did record it, so I will ask our marketing department to send out audio as well. There is a question, doesn't each employee have their own measurement period? And I think this is the last question I see. And that is for, generally for your existing employees, you put them in the same measurement periods. Although you can have different measurement periods based on different bona fide business classifications. For example, if you have 2 office locations, You may use one measurement period for that office location or another for a different office location. Or if you have salaried versus hourly employees, maybe you want to use one measurement period for that group and one for the other. It really becomes new hires. New hires sort of get into their own bucket of measurement periods. Now, you can start measurement periods for new hires as of the date they are hired, or you can start it as of any day from the date they're hired up until the first day of the following month. So, example, if somebody was hired today on April 28th, you could start their measurement period on May 1st. And employers oftentimes like to do that so they can bunch a group of their new hires all into the same measurement period so that they don't have a different measurement period for every new hire. Okay, I think that wraps us up. I'm a few minutes over due to questions. I do appreciate your time. I hope this was informative to you. I will take a review of the questions to make sure I think I got to all of them, and if we did not, we'll make an attempt to reach out to you. But thanks very much for your time, and hope you have a great day and attend one of our upcoming events. Take care.